Hello, my name is Lori Dixon, and today I will be discussing the advanced nursing practice issue of eliminating prescriptive authority restrictions for APRNs in Kentucky. Specifically, I will focus on the continued requirement of a collaborative agreement for prescriptive authority for controlled substances, also known as a CAPA CS, and how this limits full practice authority and impacts access to care. Advanced Practice Registered Nurses, also known as APRNs, practice under one of three models: full, reduced, or restricted authority. Kentucky is currently classified as a reduced practice state. While APRNs can prescribe non-controlled medications independently, they must maintain a CAPA CS agreement with a collaborating physician in order to prescribe controlled substances. This requirement limits APRN autonomy and contributes to ongoing disparities in healthcare access, particularly in rural communities. The Institute of Medicine recommends that APRNs practice to the full extent of their education and training. However, regulatory barriers, such as state-level prescriptive restrictions, prevent this from occurring uniformly across the United States. In Kentucky, APRNs must complete a 4-year collaborative agreement, among other requirements, before they may remove their CAPA CS agreement with a collaborating physician. This involves documented meetings, prescription monitoring reviews, and often financial reimbursement to collaborating physicians. Although this is intended to promote safety, evidence does not support improved patient outcomes with this restriction. Instead, it increases administrative burden and cost. The CAPA CS requirement creates both financial and professional challenges. APRN practices, which have become a growing trend in the United States, often pay collaborating physicians for this agreement, which increases operational costs and may limit service expansion. Ethically, this creates concerns related to justice and equity. APRNs are educated and nationally certified providers, yet the regulatory structure reinforces a hierarchy that undermines their professional autonomy. In rural Kentucky, where physician shortages are significant, these restrictions further reduce access to primary care and controlled substance management, worsening healthcare disparities. To overcome this challenge, legislative reform is required to eliminate CAPA CS requirement entirely. However, systemic change must accompany legislative change. Institutions should promote APRN-led leadership councils and remove language such as supervision to reflect partnership rather than hierarchy. Additionally, fellowship programs and structured transition to practice programs may increase physician and public confidence in APRN autonomy. By shifting perception and policy simultaneously, full practice authority can be achieved. In conclusion, the CAPA CS requirement in Kentucky continues to limit APRN autonomy, increase costs, and restrict healthcare access, particularly in underserved communities. Removing this barrier would align Kentucky with national recommendations, improve health equity, and support better patient outcomes. I would like to leave you with 2 discussion questions today. The first, should full practice authority be federally standardized to eliminate state variations? And second, what strategies can APRNs use to effectively advocate for legislative reform in restrictive states? Thank you, and I appreciate your time.